Hi, my name is Astrid Salazar. I go to talk about amebic abscess. Definition: amebic abscess is the most common gastrointestinal manifestation of the protozoa. In Amoeba histolytica, the life cycle involves consumption of fecally contaminated food and water that reach and penetrate the small intestine to enter the mesenteric, bowels, and finally the liver.
Hello, here is a slice of the liver, and we can see that there is a localized abnormality here. The rest of the liver parenchyma appears more or less unremarkable. So this is a cavitating lesion, and this actually is an amebic abscess. An amebic abscess is an abscess caused by the protozoal organism Amoeba histolytica. And let's take a closer look. Classically, the appearance of this abscess is a cavity with this very shaggy and friable material clinging on to the edges of the cavity. This represents necrotic material and fibrinous exudates. In the fresh abscess, we can actually see often this brownish pasty kind of liquid material within, and that is often compared to anchovy sauce. The organism gets to the liver via the portal venous system, and what happens is that it starts off in the gastrointestinal tract as an infection that occurs from the fecal oral route. The organism burrows into the colonic epithelium, giving rise to ulcers, and it eventually finds its way into the splanchnic and then portal circulation and travels to the liver and can give rise to these very large abscesses. Depending on where the abscess is located, sometimes if it is very close to the diaphragm, there are instances where these abscesses can actually burrow all the way to the pleural cavity to cause an empyema or even a lung abscess. Here is a histologic picture taken from the Patho Picture Resource, PathoPic, and we can see these kind of ovoid, very plump-looking organisms are Amoeba histolytica organisms. Sometimes they actually ingest red blood cells, so we may see them in the cytoplasm. They almost resemble macrophages, so they can be quite easy to miss. A very good special stain that we do to pick them up or to highlight them is the PAS stain, and you can see them very, very clearly staining up with this reddish color. So to summarize, we are looking at an amebic abscess, and this is caused by the organism Amoeba histolytica. It comes in through the portal circulation from the colon, and classically it has this very shaggy necrotic appearance, and usually the abscess will contain brownish pasty material that resembles anchovy sauce.
Applications in medicine. Histolytica affect about 500 million people worldwide. The excellent prevalence is difficult to discern due the high prevalence of colonization with the morphology intelligent commensal. In Tomeba dispar, metronidazole is the main treatment for amebic abscess.
Hello everyone, welcome to our channel. Today's topic is amebic liver abscess. Introduction. The causative agent is Amoeba histolytica. It is an anaerobic parasitic amoeba, more commonly in the alcoholic and cirrhotic patients. It is also called as tropical abscess. It is usually sterile unless infected. Trophozoites are found in the wall abscess, not in the content. Amebic liver abscess more commonly in the right posterior superior region. Course and its sequel. If the rupture into the lungs, then expectoration of the chocolate-colored sputum and natural regression of the abscess. If rupture into the peritoneum, the peritonitis will occur. Rupture into peritoneal cavity, then empyema, retroperitoneal abscess, and rupture into the skin. Pathogenesis. First, the infection from the colon and cecum occurs. Amoeba histolytica reaches the hepatocytes via superior and inferior mesenteric veins and portal veins. Then, hepatocytes are destroyed and multiple microabscesses are formed. Liquefaction necrosis, thrombosis of the blood vessels, and releasing and breaking of red blood cells. Now, the formation of the chocolate brown colored and odorless pus, which is sterile and also known as anchovy sauce pus. Clinical features: fever, loss of weight, chills, rigors, non-productive cough, shoulder pain. Pain in the right hypochondriac region, soft, tender, smooth liver with increasing liver span, intercostal tenderness, and mild jaundice. Now, if the complication occurs, the rupture of the rupture, infection, septicemia, and liver failure may occur. Differential diagnosis: in acute type, acute cholecystitis, acute presentation of the hepatic cell carcinoma, subphrenic abscess, and pyogenic liver abscess are the differential diagnoses. In the chronic abscess, hepatoma. Investigation: total count, which is increased, liver function test. In this, the bilirubin increases and albumin decreases. USG, chest X-ray, CT scan, sigmoidoscopy, and colonoscopy. Now, the treatment: metronidazole, tinidazole, injection of dihydroamidine, chloroquine, aspiration under USG for the large abscess, percutaneous drainage by pigtail catheter insertion, surgery for the recurrence thick pus multilocular or ruptured abscess. Thank you.
Pros and cons. The complications of the abscess are the rupture in the abdominal cavity, thus inherent through communication with the thorax on rare occasion. Communication with the big duct in the relation to trem, metronidazole, tinidazole, and nitazoxanide have some activity against the amoeba histolytica cystis. They are not sufficient to eradicate them. Is applied in Ecuador.
Let's talk about amebic liver abscess. So, history. It is common in males, about 20:1 ratio, and there is a history of an attack of amebic dysentery. Now, symptoms. Symptoms are fever with chills and rigors, loss of weight, non-productive cough, shoulder pain, and pain in the right hypochondrium, which is seen in about 90% of the cases. The signs are soft, tender, smooth liver with increased liver span in 70% of the cases. Right-sided pleural effusion may be evident. Mild jaundice is not uncommon, especially in cirrhotics and multiple abscesses. Tenderness, rigidity, and skin edema in right hypochondrium may be present in acute cases. And in chronic amebic liver abscess, smooth, firm, hard, and non-tender liver may be palpable. Investigations. In blood, leukocytosis is seen. Liver function test can be done where prothrombin time is widened, ALP, SGPT, SGOT are altered, and bilirubin and albumin level are altered. Ultrasonography of hepatobiliary system can be done, which is about 90% sensitive. Chest X-ray, CT scan, and others can be done. Now, treatment. The treatment of choice is metronidazole, which is about 400 to 800 mg 3 times daily for 7 to 10 days. Or tinidazole 600 mg twice can be given for 5 days. Imidine and chloroquine can be given, and ultrasound guided whiteboard needle aspiration can be done. The follow-up. After completion of treatment, a repeat ultrasonography or CT of the liver is done to see the resolution. Pathogenesis of amebic liver abscess. Ingestion of amebic cyst by fecal-oral route, and then development of trophozoite forming the colon, and then passing through the bowel wall, and then entry into the liver by portal vein, then localization causing liquefactive necrosis, and formation of liver abscess. That's it. End of the topic.
Is applied in Ecuador. The diagnosis of amebic abscess is made through a combination of characteristics fitted of image and serology tests and images the intrahepatic cavity that usually indistinguished from other causes of as abscess. Conclusion. In conclusion, the clinical support of live abscess is essential when making in diagnosis. The timely diagnosis of the patient with the live abscess and the initiation on target treatment reduce the morbidity and mortality of patients. The use of antibiotic therapy as reduces the risk antimicrobial resistance and reduces the hospitalization of patients. Thanks.